Hello everyone. In this lecture, we are going to discuss about a very important topic, that is iron metabolism. Okay. So this topic is really important before we can study the iron deficiency anemia and the hemochromatosis. Okay. So let's start with the distribution of iron. So iron in our body is predominantly present inside the hemoglobin. So hemoglobin is nothing but heme plus globin, as we have discussed previously, and heme is protoporphyrin plus the iron molecule. Okay. So around 65% of our iron is present inside the hemoglobin. So that is the most abundant form. Then there is another iron containing protein that is known as myoglobin. Around 6% of iron is present in the myoglobin. Myoglobin is present in the, it is present predominantly in the type 1 muscle fibers. Type 1 muscle fibers. These are also known as the red muscle fibers. This red color is because of the myoglobin. We will discuss more on this later. Then there are various enzymes inside our body, like the enzymes of electron transport chain, and also some of the enzymes on Krebs cycle, and also there are various enzymes in the peroxisms like catalase and peroxidase. They also contain iron. So this amounts to around 3.9% of the iron. Then transferrin bound iron. So iron, the free iron in the circulation, it is bound to transferrin. We'll discuss a lot more about this in the subsequent slides. So transferrin bound iron, it is around 0.1%. So 0.1% of the iron is circulating in the blood by binding to the transferrin molecule. Then the last one is the storage form. Around 1/4 of the iron, that is around 25% of the iron, is present as the storage form. Okay, so it is present as storage form. Okay, so there are three important questions. The first thing is the amount of the percentage of iron that is bound to, that is present in the hemoglobin, that is around 65%. Then the transferrin bound iron, that is 0.1%. Then the storage form of iron, that is 25%. Now this storage form, it can be in the form of ferritin, or it can be in the form of hemosiderin. So after the iron is taken into the cells, it will be utilized for heme synthesis. It will also be incorporated into the enzymes. And whatever iron is left inside the cell, that will be stored as ferritin. And whenever there is excess of iron inside a cell, the ferritins can be converted to hemosiderin. Okay, so these are the important storage forms. We'll discuss more on hemosiderin in the next slide. But before that, what are the predominant sites of ferritin? So there are 4 important organs. These are the 4 important organs where we are going to get the maximum number of ferritin molecules inside our body. So these are liver, spleen, bone marrow, and skeletal muscles. Liver, spleen, bone marrow, and skeletal muscles. The important point to note is in the liver, the ferritin molecules, the most of the ferritin molecules we are going to get in the hepatocytes. But inside the spleen and bone marrow, most of the ferritin you are going to get in the macrophages. Okay, so storage form, there are 2 forms, ferritin and hemosiderin. The first storage form is ferritin, and whenever there is excess of iron, the ferritin can be converted to hemosiderin. Okay, and this ferritin in our body, there are 4 important organs where you are going to get them. The majority of the ferritin is present in these 4 organs: liver, spleen, bone marrow, and skeletal muscles. What is important to notice, in the liver, we are going to get this ferritin inside the hepatocytes. Of course, you will also get in the macrophages, but predominantly we will find in the hepatocytes. And spleen and bone marrow, predominantly we are going to get this in the macrophages. All these things are important. When we will study the hemochromatosis, we'll get to know the importance of all these things. So now we'll see how this ferritin is converted to hemosiderin. So whenever the cell wants to store the iron, first it will store in the form of ferritin. Ferritin is actually soluble. This is a soluble form. Okay, so these are soluble forms. And iron can be easily mobilized from this ferritin. Okay, so whenever there is decreased iron, or whenever there is increased demand of iron in our body, iron can be mobilized from these storage forms. Especially they are mobilized from the ferritin. Okay, it is difficult to mobilize iron from the hemosiderins. Okay, so hemosiderins are nothing but aggregation of ferritin micelles. Okay, so these are aggregates of ferritin micelles. So what happens whenever there is excess of ferritin? They'll go into the lysosomes. And now these ferritin micelles, they'll tend to aggregate inside the lysosomes. Okay, they will tend to aggregate inside the lysosome. So what is this? So this is the lysosome. And these are the ferritin molecules which are aggregating inside the lysosomes. And inside the lysosome, they will be partially digested. So this partially digested aggregated form of ferritin is known as the hemosiderin. Okay, this is known as hemosiderin. And this hemosiderin is insoluble. It is insoluble and it is difficult to take the iron out of this hemosiderins. So iron inside the hemosiderin is less mobilizable. But iron inside the hemosiderin is reactive. Though it is less mobilizable, it is reactive. It is reactive. Okay. Normally, only trace amount of iron, only trace amount of hemosiderin is present in our body under normal circumstances. Okay. Only trace amount of hemosiderin is present under normal circumstances. Whenever there is excess of iron, you are going to get more and more hemosiderin. This hemosiderin can be seen under light microscopy with normal H&E stain. As you can see here, these are this golden brown pigments. Okay, so this is normal H&E stain. And you can see the golden brown pigments. So these are actually hemosiderins. These are the golden brown pigments which you can identify under the normal H&E stain. But if you want to do a special stain, so there is also a special stain for this hemosiderin that is known as the Pearl's Prussian blue stain. So Pearl's Prussian blue stain. So what happens in Pearl's Prussian blue stain? So in this, we have potassium ferrocyanide. And when this reactive iron molecule inside the hemosiderin, this will act upon this potassium ferrocyanide. It will be converted to ferric. Ferric ferrocyanide. And this ferric ferrocyanide will give the blue-black color. It will give the blue-black color, which you can identify in the Pearl's Prussian blue stain, and this is the principle. So potassium ferrocyanide, once the reactive iron molecule will react with this potassium ferrocyanide, they will form this ferric ferrocyanide, and that will give the blue-black color. So as you can see here, this is the Pearl's Prussian blue stain, and you can appreciate that these are the blue-black pigments. These are the hemosiderins. Okay. So hemosiderins can be identified in the normal H&E stain as golden brown pigments. And if you want to do a special stain, it is known as the Pearl's Prussian blue stain, in which we use the potassium ferrocyanide, which will be converted to ferric ferrocyanide, and this will give a blue-black color. So that can be identified in the Pearl's Prussian blue stain. Okay. So this is about the ferritins and the hemosiderin. Now let us play with some of the numbers, and these numbers are also really important for us to remember. Now, what is the amount of iron that is absorbed? So let's start with what is the daily requirement. So daily requirement for males is around 7 to 10 milligram, and for females it is around 7 to 20 milligram. Why? Because females have this menstrual cycle through which the blood is getting lost, and in the blood this iron is also getting lost. So that is why females have a higher daily requirement and males have a slightly lesser daily requirement, that is around 7 to 10 milligram. Okay. And whatever iron we take, most of them are present in the heme form. Okay. So around 85% of the iron that we consume is in the heme form, and 15% is in the non-heme form. Actually, these numbers are based on the Western data. In the Western food, there is predominance of the non-veg. There is predominantly made up of non-veg food. So non-veg food will contain this heme proteins. They will contain this heme form of iron. Okay. So in vegetarian food, we are not going to get more of heme form. You will get most of the iron in the non-heme form, that is the inorganic form of the iron. Okay. So as per the Western data, around 85% of the iron is present in the heme form and 15% in the non-heme form, that is the inorganic form. Okay. So non-heme is the inorganic form that you are going to get is the ferric form of iron. Okay. And among these 85% of the heme iron, 15% will be absorbed. And among the non-heme iron, only 1.5% is absorbed. Okay. Again, these numbers are also important. So heme form of iron, 85%, non-heme 15%. Among the heme form, 15% will be absorbed. Among the non-heme form, only 1.5% will be absorbed. So if you do all this calculation, the percentage of iron that is absorbed is around 10 to 15%. Again, this is the question that is, this is a question that is very commonly asked. What is the total percentage of iron that is absorbed? Is only 10 to 15%. So if you take 10 milligram of iron, you are going to absorb only 1 to 2 milligram of iron. Okay, you are going to absorb only 1 to 2 milligram of iron. Whatever amount of iron that is absorbed, it equals to the amount of iron that is lost every day. Okay, so that will be around 1 to 2 milligram. That will be around 1 to 2 milligram. How this iron is lost from the body? It is lost by shedding of the enterocytes. Shedding of the enterocytes. Enterocytes are nothing but the intestinal epithelial cells. Also, shedding of the keratinocytes from the skin. Shedding of keratinocytes. And also through the menstrual blood flow. Of course, this is only in females. So these are the routes of excretion of iron. And every day around 1 to 2 milligram of iron is getting lost. And also we absorb only 1 to 2 milligram of iron. So if there is a decrease in consumption or decrease in absorption, or also if there is increase in excretion of iron, you are going to have iron deficiency anemia. Okay, so these numbers are clear. So daily requirement for males, it is 7 to 10 milligram. For females, 7 to 20 milligram. Whatever amount of iron we consume, most of them are in the heme form. That is around 85% is present in the heme form, out of which 15% is absorbed. Rest 15% in the non-heme form, out of which 1.5% is absorbed. The total, the percentage of total iron absorbed is only 10 to 15%. Okay, so that will be around 1 to 2 milligram. And also that is the amount of iron that is lost every day through shedding of keratinocytes, enterocytes, and through the menstrual blood flow. Okay, then what is the total amount of body iron in a male? So it will be around 6 gram. 6 gram is the total amount of body iron in a male, and in females it is around 2.5 gram. It is around 2.5 grams. Okay, so these are all the numbers you have to remember. Okay, so now if you understood this, now we'll go to the actual flow of iron in our body. Okay, so as you can see here, so iron will be predominantly absorbed in the duodenum. So this is the duodenum, and this is the duodenal epithelial cells. You can appreciate that it is having the villi. In the duodenum, so iron will be absorbed in the duodenum. After getting absorbed, it will go to the circulation. From the circulation, it will go to the various cells. But what is important for us to understand is there are 3 predominant areas where the iron is going, and we have to understand what is happening in all these areas. Remember, whatever iron is there in the circulation, or whatever iron is absorbed, around 70%, is going into the bone marrow. Why? Because in the bone marrow, you are having the developing erythroblasts. And developing erythroblasts, they need iron because they are synthesizing the hemoglobin. And for the hemoglobin synthesis, you need iron. So around 70% of the iron that is absorbed, it will go into the bone marrow, especially to the developing erythroblasts. Okay. Again, this number is important. Around 70% of iron is going into the bone marrow. But apart from going into the bone marrow, it will also go to the macrophages. So this is the bone marrow macrophages. Here also the iron is going. The macrophages are also predominantly present in the liver and in the spleen. So iron, apart from going into the developing erythroblasts, it will also go to the macrophages, which are present in the bone marrow, liver, and spleen. Okay, this is clear. Next point is macrophages will also take up iron. It will also take up iron from the senescent RBCs, from the extravascular hemolysis. If this is happening in the body, if extravascular hemolysis is happening, this iron will also taken up by the macrophages. Also, if there is intravascular hemolysis happening, some amount of iron will also go into the macrophages. These points we have already discussed previously in the concept of hemolytic anemia. When we discussed about the basics of hemolytic anemia, I have told you all these things, how the senescent RBCs, or how from the intravascular or extravascular hemolysis the iron can be taken up by the macrophages. So those things we have already discussed. Okay, so I'm not going to repeat all those things. So macrophages in various parts of the body, especially the spleen, liver, and bone marrow, they can take up iron either from the circulating iron, or they can also take up the iron through senescent RBCs, through metabolism of senescent RBCs, or if there is extravascular or intravascular hemolysis, they can also take up those iron. Apart from this, iron can also be taken up by the hepatocytes. This can be taken up by hepatocytes. We have discussed previously that in the liver, hepatocytes are predominant source of the ferritin. Okay, so iron will be taken up by the hepatocytes. But why it is important? Because liver will produce the master regulator of iron hemostasis, that is known as hepcidin. We'll discuss that later. But liver will produce hepcidin, which will regulate the amount of iron that is absorbed. Okay, so that is why the hepatocytes should know the iron status of the body. So that's why hepatocytes, they act as iron sensors. They act as iron sensors, and whenever there is excess of iron, they will produce more hepcidin so that the iron absorption can be stopped. And whenever there is less iron in the body, the liver can actually produce, the liver can actually suppress or decrease the level of hepcidin so that more and more iron can be absorbed. Okay, we'll discuss all those things in detail. So that is the significance why hepatocytes should also get the iron. Okay, apart from this, iron will also be taken up by various cells, so that all those cells can use the iron for their purpose, like synthesis of enzymes or storage in the myoglobin. So all those things can happen, but these are the important tissues where the iron is going, and we have to understand what is happening in all these cells, all these tissues, and that will make our concepts really clear about the iron metabolism. Okay, so let's start with what is happening at the level of duodenum. First, we'll discuss what will happen in the duodenum, how the iron is getting absorbed. Then we'll discuss what is happening in the macrophages, what are the things that are happening in the macrophages, and also we'll discuss what is happening in the erythroblasts, and then we'll discuss what is happening in the hepatocytes. So these are the 4 things we are going to discuss. So we'll discuss the duodenal absorption, we'll discuss what is happening in the macrophages, we'll discuss what is happening in the developing erythroblasts, and also we'll discuss what is happening in the hepatocytes. Okay, but before that, for the functions of iron inside the cell, once iron is taken into the cells, it can be utilized for heme synthesis, as I already told you. Heme synthesis predominantly happens in the bone marrow. This predominantly happens in the bone marrow, and also to a lesser extent in the liver also. Okay, heme synthesis we'll discuss later in separate video. Then iron can also be used for iron sulfur cluster synthesis. Iron sulfur cluster synthesis. This will be utilized for the electron transport chain, which is required for the oxidative phosphorylation. And also iron is utilized for various other enzymes. And whatever extra iron is there, it can be stored as ferritin. So these are the normal, functions of iron in the cells. But how the iron is taken up into the cells? So usually iron, when it is bound to transferrin, so this is actually the transferrin molecule. Iron is bound to the transferrin. It is bound to the transferrin, and it is taken up. It is identified by the transferrin receptor. So this is the transferrin receptor. And once the transferrin bound iron, it is identified by the transferrin receptor, it can be taken up into the cells through a process that is known as receptor mediated endocytosis. Okay, it is known as receptor mediated endocytosis. Okay, we'll discuss it in detail in the next slide. But right now, you remember iron, which is bound to the transferrin, it can be taken up into the cells through the process known as receptor mediated endocytosis. Okay, and once it is inside the cell, it can be used for all these functions, and whatever extra iron is there, that can be stored as ferritin. And if there is more and more accumulation of iron inside the cell, the ferritin can be converted to hemostatin that we have already discussed. Now let us start with the duodenum. How the iron is absorbed in the duodenum. So if you see, this is the duodenal epithelial cell. This is the duodenal epithelial cell. As you can see, this is having the villi, and this is of course the luminal side. This is the luminal side, and this is the basolateral side. This is the basolateral side. This is the luminal side, and this is the basolateral side. Okay. So we have, I told you there are two forms of iron. One is heme form, another one is non-heme form. And I told you heme form is the predominant form, that is around 85%, and non-heme form is the, it's the minor form, that is around 15%. Okay. So heme iron, the heme form of iron, it can be taken up by the duodenal epithelial cells directly through a protein that is known as heme carrier protein. So I'm writing it here in a short form. So HCP is nothing but the heme carrier protein. So this is the heme carrier protein which is taking up this heme. Once the heme is inside this epithelial cells, then heme oxygenase, this is the enzyme that can act upon this heme, and it can convert, it can actually release the iron. It will release the iron. Okay, and that iron, either it can be stored in the form of ferritin. Okay, this iron can be stored in the form of ferritin, and also whenever there is requirement, this iron can also be transported out of the cell. It can be transported out of the cell. How it is getting out of the cell, that we'll discuss later. But as of now, we remember heme, after getting into the cells, it can be acted upon by heme oxygenase, which will release the free iron, and this free iron can be transported out of the cell, or it can be stored in the ferritin. It is clear. So that is all about the heme form of iron. Now we'll see what is happening to the non-heme form of iron, that is the inorganic iron or the ferric iron. Now this ferric iron, it cannot be transported into the cells directly. This has to be converted to ferrous form. And who will convert it to ferrous form? It is done by a protein that is known as duodenal cytochrome B. Duodenal cytochrome B or STEAP3. STEAP3. So there are two proteins, duodenal cytochrome B or STEAP3. So these are the proteins. They have ferrireductase activity. So that they can convert the ferric form to the ferrous form. Okay, so they'll convert the ferric form to the ferrous form. In the duodenal epithelial cells, this duodenal cytochrome B is present predominantly compared to the STEAP3. STEAP3 is present predominantly in the macrophages. Okay, we'll come to that. But as of now, you remember, in the duodenal epithelial cells, we have duodenal cytochrome B in the luminal side, which is the predominant protein that is required for the reduction of the ferric iron to the ferrous iron. Okay, so now the ferric form is converted to the ferrous form. Now this ferrous form of iron can be taken up into the cells through another channel protein that is known as DMT1. So what is DMT1? DMT1 is the divalent metal transporter 1. Okay, now through this channel protein, the ferrous form of iron is taken into the duodenal epithelial cells. Now this ferrous form of iron, either it can be stored in the form of ferritin, and also it can be taken up. It can be taken out of the cell into the bloodstream. Okay, it can be taken out of the cell into the bloodstream. Now we'll see how this iron is getting out of these duodenal epithelial cells. This is possible by another protein that is known as ferroportin. So I'm writing it in a short form, that is FEN. FEN is nothing but the ferroportin. Okay, so ferroportin can transfer this ferrous form of iron from the cell to outside. Okay, once it is gone out of the cell, now this ferrous form of iron, we have to transport this ferrous form of iron to various cells in our body. Again, this ferrous form cannot be transported because ferrous form is highly toxic. It can participate in the Fenton reaction. It can produce reactive oxygen species and cause various oxidative damage. That's why we will not keep this ferrous form in the circulation. We have to convert this ferrous form into the ferric form. Now, who is converting this ferrous form to ferric form? That is known as the hephaestin. So another protein, we have another protein that is known as hephaestin. Okay, and also there is another protein that is known as ceruloplasmin. Hephaestin or ceruloplasmin. Okay, so ceruloplasmin you must have studied. If you have studied the copper metabolism, you must be knowing that ceruloplasmin is a copper-containing protein. This has peroxidase activity. Both hephaestin and ceruloplasmin, both of them have peroxidase activity. That means they can convert the ferrous form to the ferric form. Okay, and in the duodenal epithelial cells, this hephaestin is predominant compared to the ceruloplasmin. Okay, so this is clear. Now it is converted to ferric form. It can bound to a dumbbell-shaped glycoprotein that is known as the transferrin. So this is the transferrin. Transferrin. Transporting the ferric form of iron. That is why the name is transferrin. It has, it has two sides to bind to the ferric molecules. So once two molecules of ferric, two ferric molecules is attached to transferrin, this is known as diferric transferrin. It is known as diferric transferrin, or otherwise known as the holotransferrin. Holotransferrin is nothing but the diferric transferrin. Okay, so now this holotransferrin can circulate in the blood and it can provide iron to various cells. And how the cells will take up this iron? Through receptor mediated endocytosis that I have told you previously. Okay, so I hope it is clear. So this is how the iron is getting absorbed in the duodenum. Okay, so there are various proteins. I just revise it again. So iron is present either in the heme form or the non-heme form. Heme form can be directly taken up into the cell through heme carrier protein. Inside the cell, it can be acted upon by the heme oxygenase, which will release the free iron. Now, this free iron, either it can be transported out of the cell into the circulation, or it can be stored in the ferritin. Non-heme iron, or the ferric form of iron, or the inorganic iron, it will be converted to ferrous form first with the help of duodenal cytochrome B or STIP3. In the duodenum, it is the duodenal cytochrome B which is predominant. After it is converted to ferrous form, it will be taken up into the cell through a channel protein that is known as DMT1, divalent metal transporter 1. Now, this ferrous form inside the cell, either it can be stored or it can be transported out of the cells. Okay. Now, how the ferrous form of iron is getting transported out of the cell? It is by another channel protein that is known as ferroportin. Okay, and after it is getting out of the cell, this ferrous form of iron, it has to be converted to ferric form. Okay, because ferrous form is toxic, it has to be converted to ferric form so that it will be transported in the circulation. Now, this conversion happens because of peroxidase activity of two important proteins. One is hephaestin, another one is ceruloplasmin. Okay, in the duodenal epithelial cells, it is the hephaestin that is present predominantly. Okay, and once this ferric form is generated, it will bind to the transferrin molecule. And whenever two ferric molecules is bound to transferrin, that is known as holotransferrin, and now this iron can be transported in the circulation and it can be provided to various cells. And in the cells, we have transferrin receptors which will identify this holotransferrin molecule and it will be taken up into the cell through receptor mediated endocytosis. Okay, we'll come to that. But before that, we'll just see what are the factors which will increase this iron absorption. So what are the factors which will increase the absorption? And also we have to know what are the factors that can decrease the iron absorption. Now, there are certain factors which can actually reduce the iron, which can actually reduce the ferric form to ferrous form. Whichever factors or whichever substances which can reduce the ferric form to ferrous form, they can actually increase the absorption. Now, what are those factors? Examples are vitamin C, glucose, and amino acids, certain amino acids. So these things can actually reduce the ferric form to ferrous form and helps in increasing the absorption. There are certain factors which will reduce the absorption. Those includes phytates, oxalates, tannate, phosphates, and carbonates. Okay, so phytates, oxalates, tannates, phosphates, and carbonates. These are all negatively charged. They will have a negative charge and they will try to bind to iron molecule. They will try to bind to iron molecule, and that's how they prevent the absorption. So that is all about the absorption. Now we'll see so this is about the duodenal epithelial. Now we'll see what is happening in the macrophages. Now let us discuss the role of macrophages in this iron metabolism. Okay, so as you can see, this is a macrophage. Now, I have told you previously that macrophages can take up iron either from the senescent RBCs or whenever there is extravascular hemolysis, it can take up the phagocytose the RBCs and it can take up the iron molecule. And also whenever there is intravascular hemolysis, it can take up the hemoglobin haptoglobin complex and ultimately they can take up the iron. So all these things we discussed previously. Now from all this process, they will generate the heme inside the macrophages. Now this heme, with the action of heme oxygenase, it can release the free iron. Okay, so all these things you already know. Now, what else? Now, macrophages can also take up iron from the circulation. And I told you in the circulation, the iron is present bound to the transferrin, and that is known as holotransferrin. This is known as the holotransferrin. So this is the holotransferrin molecule, that is nothing but the diferric transferrin. Now, this diferric transferrin can be identified, I mean, it can be taken up into the cells once it is attached to the receptor that is known as transferrin receptor. Transferrin receptor. And the predominant form is transferrin receptor 1. There is another transferrin receptor, that is transferrin receptor 2. But transferrin receptor 2 doesn't play a major role in taking up the iron into the cells. It has a separate function that we will discuss later. Okay. So once this holotransferrin is bound to transferrin receptors, it can be taken up into the cell through clathrin-coated pits. You must have studied in the physiology that in the process of receptor-mediated endocytosis, this is known as receptor-mediated endocytosis. In this process, these clathrin proteins play a major role, because whenever the ligand is bound to the receptor, they will be taken up into the cells through this clathrin-coated pits. Okay, and once this pit is released into the cell, it can be fused with the lysosomes, and after fusing with the lysosomes, they will make this endosomes. They make the endosome. After that, what happens? Once they make this endosome, there will be influx of proton molecules or H plus molecule into the cells, into this endosome. Okay, so influx of H plus molecule into the endosomes, and that will create a acidic environment inside the endosome. Okay, once they make an acidic environment of around pH of 5, once they make the pH of endosome of around 5, the iron molecules, the ferric molecules, can be released from the receptor transferrin complex. Okay, so as you can see here, once the pH is around 5, there will be breakage of this attachment, and the iron can be freed, and the ferric molecule is freed, and the receptor transferrin complex is separated. Okay, so once they are separated, now this receptor transferrin complex can go into the cell surface, from where again this transferrin molecule can go into the circulation, and whatever is left inside the endosome is just the iron molecule, just the ferric molecule. Okay, and this ferric molecule now it can be converted to ferrous form. It can be converted to ferrous form, because ferrous form can only be transported out of this endosome. Okay, ferric form cannot be transported out of the endosome, so it has to be converted to ferrous form. Now, who will convert the ferric form to ferrous form? Here I have told you the ferric form is converted to ferrous form by duodenal cytochrome B and STIP3. Okay, and I have told you duodenal cytochrome B is the predominant ferrireductase present in the duodenal epithelial cells, and STIP3 is the predominant ferrireductase which is present in the macrophages. So now the role of STIP3 will come. So STIP3, this is the ferrireductase which is predominantly present in the macrophages. Now this will reduce the ferric form to the ferrous form. Okay, and now this ferrous form can be taken off out of this endosome with the help of this, again with the help of DMT1, that is divalent metal transporter 1. Okay, so now the iron is free. Now the iron is available inside the macrophages for various functions. Predominantly, the iron in the macrophages, it is stored in the form of ferritin. It is stored in the form of ferritin. Okay, so predominantly, this macrophages will keep the iron in the form of ferritin. Whenever there is requirement of the iron, this macrophages can release iron from the ferritin, and it can supply to various cells in the body. Okay, so macrophages, they act as predominant storage form of the iron. Okay, in the form of ferritin. Okay, now some of this ferritin can go into the circulation. And whatever we measure in the circulation, the serum ferritin, this is nothing but this ferritin which is released slightly from the macrophages. Okay, and this serum ferritin actually gives us an idea about the iron status of the body. Okay, so if serum ferritin is high, the iron in our body is sufficient, and whenever it is low, that means the body is iron deficient. Okay, we'll discuss more on serum ferritin later, but as of now, remember this ferritin, whatever is stored inside macrophages, some of this ferritin can come into the circulation, and they act as surrogate marker for iron status of the body. Okay, and I told you whenever there is requirement of iron, this macrophages can supply the iron from the ferritin, and this iron can be released out of the cell through again this same protein, that is ferroportin. So ferroportin, it is present predominantly in the duodenal epithelial cells on the basolateral side, and also they are present in the macrophages. Whenever there is requirement of iron, these macrophages can send the iron molecule out of the cell through this ferroportin molecule. Okay, so once this ferrous molecule is out of the macrophages, again it has to be converted to ferric form, and this happens through the celluloplasmin. This happens by celluloplasmin. I have told you there are two proteins which have ferroxidase activity, which can convert ferrous form to ferric form. In the duodenum, it is predominantly hephaestin, and in the macrophages, it is predominantly ceruloplasmin. Okay, predominantly ceruloplasmin, which can convert the ferrous form to the ferric form. Now, this ferric form can bind to the transferrin and it can be circulated in the blood, and it can provide iron to various cells inside the body. Okay, so this concept is clear. So this is the role of macrophages in the iron metabolism. Okay, so now once we understood this, now we'll discuss what happens in the erythroblasts. Okay, just for the sake of completion, this hemoglobin haptoglobin complex can be taken up by the macrophages by the help of a receptor that is known as CD163. It's not very important to remember, but just for the sake of completion, I'm telling this. Okay, so we have discussed what happens in the duodenum, we have discussed what happens in the macrophages. Now we'll discuss what happens inside the bone marrow. I have told you in the bone marrow, the iron will be taken up by the developing erythroblast and by the macrophages. This I have already discussed macrophages. Now we'll see what happens in the erythroblasts. I told you around 70% of iron that is getting absorbed will go to the bone marrow. Why? Because this developing erythroblast, because they are synthesizing the hemoglobin, they need the majority of the iron. And that is why they express very high amount of transferrin receptors. So all these are transferrin receptors. So if someone asks you, which cell in your body has the maximum concentration of transferrin receptor, the answer is developing erythroblast. So this is actually a developing erythroblast. This is a developing erythroblast, and this has the maximum concentration, maximum amount of transferrin receptors. So that is why they will take the majority of the iron. They will take up the majority of the absorbed iron. Okay. Okay, of course, the iron will be taken up through the process of receptor-mediated endocytosis. I'm not going to discuss that again. We already know whichever cell is taking iron from this holotransferrin, they have to take it through receptor-mediated endocytosis. Once the iron is inside the cell, it can be used predominantly in the erythroblast. They are used predominantly for heme synthesis. And we have discussed previously that heme synthesis, the final step happens inside the mitochondria, where the iron will be attached to the protoporphyrin with the help of ferrochelatase. So that is why iron has to be taken up into the mitochondria. It has to be taken up into the mitochondria where they are used for heme synthesis. Okay. After utilizing for its purpose, whatever extra iron is there, it can be stored as ferritin. It can be stored as ferritin, and sometimes whenever there is more amount of iron, it can be converted to hemosiderin. It can be converted to hemosiderin. Okay. One more point you can appreciate here, that in a developing erythroblast, okay, in a erythroblast, the normal arrangement of mitochondria is around the nucleus. So this is known as perinuclear arrangement of mitochondria. Perinuclear arrangement of mitochondria. So this is actually perinuclear arrangement of mitochondria. This is actually a normal phenomenon inside the developing erythroblast. The mitochondria they are arranged surrounding the nucleus. Okay, what is the significance of this? I will tell you. Okay, so what happens? I told you that whenever there is little bit extra amount of iron in a developing erythroblast, it can be stored as hemosiderin. Okay, now this hemosiderin can be identified by Prussian blue stain. Okay, it can be identified by the Prussian blue stain. So if you do Prussian blue stain, around 30% of the developing erythroblast will show some amount of hemosiderin deposition in the cytoplasm of the developing erythroblast. So as you can see here, this is a developing erythroblast. And after applying the Prussian blue stain, you can see these are the hemosiderin pigments. These are the hemosiderin pigments you can identify. And this will be present in around 30% or 1/3 of the developing erythroblast. And these are known as the sideroblasts. These are known as the sideroblasts. These are known as sideroblasts. Okay. So if they ask you what is the normal percentage of sideroblasts you are going to get inside the bone marrow, it is around 30%. Okay. So amount of sideroblasts is 30%. Why these are called as sideroblasts? Because if you do Prussian blue stain, you are going to get some amount of hemosiderin pigment in the cytoplasm of this developing erythroblast. Okay. The amount is 30%. 30% of the erythroblast will show some amount of hemosiderin deposition. But there is a condition that is known as sideroblastic anemia. Sideroblastic anemia. So what happens in this sideroblastic anemia? In sideroblastic anemia, the iron cannot be utilized for heme synthesis. The iron cannot be properly utilized for heme synthesis. So there will be excessive accumulation of iron inside the developing erythroblast. Okay, excessive accumulation of iron. So in these patients with sideroblastic anemia, there will be excessive hemosiderin deposition in the cytoplasm, and also there will be excessive amorphous iron accumulation in the mitochondria. As you can see here, there is excessive hemosiderin deposition in the mitochondria also. And this perinuclear arrangement of, the perinuclear arrangement of hemosiderin inside the mitochondria, this will give rise to appearance of ring sideroblast. Ring sideroblast. Okay, because mitochondria is normally arranged perinuclearly inside the erythroblast, and in patients with sideroblastic anemia, there will be excessive iron accumulation, and the iron cannot be utilized for heme synthesis. There will be excessive iron accumulation in these mitochondria, which are arranged already present perinuclearly, and this perinuclear arrangement of hemosiderin pigments is described as ring sideroblasts. So ring sideroblasts are classically seen in patients with sideroblastic anemia. Not all patients of sideroblastic anemia, but most of the patients with sideroblastic anemia, we are going to get this ring sideroblasts. Okay, we'll discuss more on this when we'll discuss about the sideroblastic anemia and also in myelodysplastic syndrome. But this is the basic concept. So normally we can find sideroblasts in 30% of the developing erythroblast, but if the amount of hemosiderin is excessive in the cytoplasm, or if the hemosiderins are present in the perinuclear location inside the mitochondria, those are abnormal and those are classically seen in sideroblastic anemia. Okay, so now we have discussed about the duodenum. Now we have discussed about the macrophages. We have discussed about the bone marrow, the developing erythroblast. Now we'll see what is happening in the hepatocytes. Okay, so this is very important. So inside the liver, again, it can be taken up by the macrophages. This we already discussed. Now we'll see what is happening in the hepatocytes. Hepatocytes, like any other cells, they will utilize the iron for their purpose. They will utilize for heme synthesis. They will also utilize this for enzyme synthesis. But apart from that, hepatocytes also need iron sensing for the production of hepcidin, which is the master regulator of iron homeostasis. So here I will just describe the hepcidin production and its regulation, and how hepcidin is regulating the iron homeostasis. Okay. So inside the hepatocytes, inside the nucleus, there is a gene that is known as HAMP gene. This is known as HAMP gene. And this HAMP gene, the product of this HAMP gene is hepcidin. Okay, the product of this gene is hepcidin. This is very important. So then we'll understand what is the normal function of hepcidin. What is the normal function of hepcidin? So normal function of hepcidin is it will go and it will cause a degradation of the ferroportin protein. Okay, so as you can see, ferroportin is predominantly present in the duodenal epithelial cells on the basolateral side, and also it is present in the macrophages. And in all these cells, what is the normal function of ferroportin? It is causing release of the iron from the cells towards the circulation. Function of hepcidin is to cause endocytosis and degradation of the ferroportin. So it will cause endocytosis and degradation of ferroportin. So whenever there is excessive hepcidin, the ferroportin is suppressed, the ferroportin is degraded, and so there will be no absorption of the iron, and also there will be no release of iron from the macrophages. Okay, so whenever there is excessive ferritin, whenever there is excessive hepcidin, there will be reduced absorption of iron from the duodenal epithelial cells, and also there will be reduced release of iron from the macrophages. That is the normal function of hepcidin. So whenever body has enough iron source, it will produce more hepcidin, and whenever body has less iron source, it will suppress the hepcidin production so that more iron can be absorbed and more iron can be released from the macrophages. So that is the basic concept behind this production of hepcidin. Okay. Now, how these hepatocytes will know that there is enough iron? How they know that there is enough iron? So they can identify this with the help of this transferrin receptors. So this is actually the transferrin receptor. I told you it is a transferrin receptor 1, which is predominantly taking up this holotransferrin. So as you can see here, this is the transferrin receptor 1 complex. And you can appreciate that there is another protein molecule which is attached to this transferrin receptor 1. What is this protein? I'll just write here. So this protein is HFE. This protein is HFE. This one. Okay. So the protein which is bound to the transferrin receptor complex, it is nothing but the HFE. Okay. So now we'll see what is happening. So once holotransferrin is bound to this transferrin receptor, once this holotransferrin is bound to the transferrin receptor, it can actually release the HFE molecule. It can actually release the HFE molecule. Now this HFE molecule is ready to bind another transferrin receptor that is known as transferrin receptor 2. I have told you previously that transferrin receptor 2, it doesn't play a role in taking up the holotransferrin. It has a different function. What is that different function? As you can see here, whenever the holotransferrin is attached to transferrin receptor 1, this will cause release of HFE molecule. Now this HFE molecule can come and bind to the transferrin receptor 2. Now once this HFE molecule is bound to transferrin receptor 2, they can give signal to produce more and more hepcidin, Okay. So I will just repeat it again, how the hepatocytes is understanding that there is enough iron. They know there is enough iron because they have the transferrin receptors which can identify the holotransferrin. And once this holotransferrin is bound, the hepatocytes know, okay, there is enough iron. We have to produce hepcidin to reduce the absorption and also to reduce the release of iron from the macrophages. Okay. Now what happens whenever this holotransferrin is bound to transferrin receptor 1, the HFE molecule is released, and this HFE molecule can go and bind into the transferrin receptor 2. That will give signal to produce hepcidin. Okay, this part is clear. But there are certain other proteins, and these proteins are known as bone morphogenetic proteins. These are known as bone morphogenetic proteins. These small proteins, these are bone morphogenetic proteins. These bone morphogenetic proteins can also increase hepcidin production through the START pathway. That is not important. Just remember that bone morphogenetic proteins, it can also increase the hepcidin production. Okay, so these are the bone morphogenetic proteins, and this receptor is not just bone morphogenetic protein receptors. So these are BMPRs, bone morphogenetic protein receptors. But there is another special molecule which is very important to remember. That molecule is known as hemojuvelin. So this molecule, this protein, which acts as a co-receptor along with the bone morphogenetic protein receptor, it also acts as a co-receptor. This is known as hemojuvelin, HJV, hemojuvelin. So this hemojuvelin is actually a GPI anchored protein. This is a GPI anchored protein which is attached to the bone morphogenetic protein receptor, and it also helps in this recognition of the bone morphogenetic proteins. It also helps in the sensing of this bone morphogenetic proteins, and also it helps in producing the hepcidin. Okay. And there is another regulator. There is a regulator for this hemojuvelin also. That regulator is matriptase 2. Matriptase 2, or it is known as the TMPR SS6. Okay. So matriptase 2 or TMPR SS6. This is the molecule which can actually inhibit or which can degrade the hemojuvelin molecule. Okay, it can degrade the hemojuvelin molecule. So I'll just highlight it. So all these points are very important. All these points are very, very important when you will study about the iron deficiency anemia, and also when you study about the hereditary hemochromatosis. Okay. So I'll just repeat it again. So there are certain proteins, those are known as bone morphogenetic proteins, which can be taken up by the hepatocytes through bone morphogenetic protein receptors. And this receptor also has a co-receptor, which is known as the hemojuvelin. And this receptor complex, when they identify the bone morphogenetic proteins, they can activate the START pathway, and through that process, it can increase the hepcidin production. And there is another negative regulator of hemojuvelin that is known as TMPRSS6 or matriptase 2. Now, can you tell me what will happen whenever there is a mutation, whenever there is loss of function type of mutation in this matriptase 2? So if you have loss of function type of mutation in matriptase 2, it cannot degrade the hemojuvelin. There will be increased activity of hemojuvelin. That will cause increased hepcidin production. And whenever there is increased hepcidin production, it will block the iron absorption from the duodenum, and also it will block iron release from the macrophages. So that will cause iron deficiency anemia. That will cause. So if there is a loss of function type of mutation in matriptase 2, it can cause iron deficiency anemia because it is increasing excessive, it is causing excessive production of the hepcidin. But one more point you have to appreciate that in these patients, even if you supplement iron through oral route, it cannot be absorbed from the duodenum. It cannot be absorbed from the duodenum. So that is why this is a condition. This is a condition of iron deficiency anemia which will not respond to the oral iron supplement. That is why this condition is known as iron refractory iron deficiency anemia. Again, a very important question. What is the cause for iron refractory iron deficiency anemia? That is Macrophages 2 or PMPRSS6 mutation. Okay. And one more point. I have told you previously that the developing erythroblast, when I discussed about the thalassemia, I told you whenever there is excessive erythropoiesis, this developing erythroblast, they will produce a substance that is known as erythroferron. Erythroferron can inhibit hepcidin production. But what is the exact mechanism? Actually, the erythroferron, which are coming from the developing erythroblast. As you can see, this is the developing erythroblast, and they can produce this molecule erythroferron. This erythroferron can actually inhibit the bone morphogenic proteins. They act as a ligand trap. Okay, so they will not allow these bone morphogenic proteins to interact with the bone morphogenic protein receptors. Okay, so with this process, they can actually cause reduction in hepcidin production. Okay, so erythroferron, as we have discussed previously, it decreases hepcidin production, and the exact mechanism is it is actually inhibiting the bone morphogenic proteins. Okay. Now, coming to the last section, I know it's slightly tough, but all these points are important, and you have to see this video at least 2 to 3 times to understand it and memorize it. Okay, so there is another molecule that is known as interleukin 6. So this is interleukin 6. Interleukin 6 is a it's an inflammatory marker, inflammatory mediator, which is produced whenever there is inflammation. And this interleukin 6, it can also activate the start pathway, and it can also increase the hepcidin production. Now, this is important when we will discuss about the anemia of chronic disease. Anemia of chronic disease, what happens? There is persistent inflammation, and that will produce increased amount of interleukin 6. This interleukin 6, by increasing the hepcidin, can cause a state of iron deficiency anemia. Okay, so in patients with anemia of chronic disease, we are going to get a picture similar to iron deficiency anemia, and the mechanism behind that is this. So interleukin 6 can actually increase the hepcidin production. Okay, so that completes all these mechanisms. I'll just revise it again. So in the hepatocytes, in the hepatocytes, there is a inside the nucleus we have HAMP gene. HAMP gene can produce the hepcidin. Function of hepcidin is to cause endocytosis and degradation of ferroportin. And normal function of ferroportin, as we all know, it can take up, it causes release of iron from the duodenal epithelial cells into the circulation, and also it causes release of iron from the macrophages into the circulation. Okay, and hepcidin is blocking all this process. Now, how hepcidin synthesis is increased? There are 3 important pathways. The first one is whenever the hepatocytes identify the holotransferrin, the HFE molecule from the transferrin receptor 1 can be released, and it can go and bind to the transferrin receptor 2. This transferrin receptor 2 and HFE complex increase the hepcidin production. That is one part. Second part is about the bone morphogenic proteins. Bone morphogenic proteins, when they are identified by their receptor complex, the receptor complex is constitutes of bone morphogenic protein receptor and also hemojuvelin. Okay, so whenever this bone morphogenic proteins, they are bound to this receptor complex, they can increase the start pathway and they can increase the hepcidin production. Okay, and there is a negative regulator of this bone, this hemojuvelin, that is known as the Macrophages 2 or PMPRSS6. Mutation of that can cause iron refractory iron deficiency anemia. And also we have discussed erythroferron. Erythroferron act as ligand trap for bone morphogenic proteins. They will not allow the bone morphogenic proteins to interact with the receptors. So that is the way they can actually cause reduction in the hepcidin synthesis. Okay, and the third mechanism is interleukin 6. Interleukin 6, by binding to its receptor, interleukin 6 receptor, it can cause increase in hepcidin production. Okay, so that is all about the regulation of iron, okay, through the hepcidin. Now, I just want to discuss one more important concept. So can you tell me what is going to happen whenever there is transferrin receptor 2 or HFE mutation? Okay, let's just see, write it. Let's see this. If there is a mutation in transferrin receptor 2 or there is a mutation in HFE, or loss of function type of mutation. if there is loss of function type of mutation in the transferrin receptor 2 or HFE molecule or hemojuvelin or this hump gene or this hump gene, or you can say hepcidin mutation, or you can say hepcidin mutation, and also ferroprotein mutation. Can you tell me what will happen whenever there is mutation in all these proteins? So whenever there is loss of function mutation, TFR2 or HFE or hemojuvelin or hump gene, there will be decreased production of hepcidin. So hepcidin will not be produced if there is mutation in all these things. So that will cause increased iron absorption and increased iron storage inside the macrophages, and that will cause a condition that is known as hereditary hemochromatosis. Okay, and the most common cause of hereditary hemochromatosis is HFE gene mutation. Okay, more on this we'll discuss when we'll discuss about the hereditary hemochromatosis. But remember, mutation in all these can cause hereditary hemochromatosis. Okay, and mutation in FPN, that is ferroprotein, this is a special type of mutation. In this condition, there is nothing to do with hepcidin, but in this condition, the iron cannot be released from the macrophages. So that also can cause a special type of hereditary hemochromatosis because there is excessive iron accumulation inside the macrophages. Okay, so that we'll discuss later. But as of now, remember, mutation in any of these can cause hereditary hemochromatosis, and most common cause is HFE mutation. Okay, so again, this is a lengthy discussion, but remembering or understanding all these concepts are really, really important to understand the disease better. Okay, so thank you. So if any doubts, you can always ask me. You can always put in the comment section.